Good morning. Okay, all right, so this is another funny comic here. This person is at the tanning booth, and then they see the different rates for the different skin cancer, okay? So if you think back, some of us have been in a lot of tanning booths before, especially where I trained on the mainland. That was very, very popular. So I want you to raise your hand if you enjoy being outside in the sun during doing hobbies or being out with your grandkids, your kids. Raise your hand. Okay, you can put your hands down. Raise your hand if you or someone you know has had a skin cancer before. So many people. It's becoming so common, especially here in Hawaii. So my name is Dr. Westley Mori. I was born and raised here in Kailua, Hawaii. I went to University of Pittsburgh School of Medicine and then did my dermatology residency and Mohs Micrographic Surgery Fellowship at University of Minnesota. So I am the kid right here, right there, okay? That was in 1992, okay? I work at Mohs Hawaii, which is a private practice in Queens Physician Office Building 2, and then, like we mentioned, I'm an assistant clinical professor here at John A. Burns School of Medicine. So I have no relevant financial disclosures. So why is this important? Well, skin cancer is very common, especially among older adults. But early detection can save lives by treating problems while they're still small and have relatively lower morbidity. So anyone can get skin cancer no matter your skin tone. Patients often ask me if this happens only to patients who have fairer skin, but I do have a fair number of patients who are of darker skin tones. Here in Hawaii, we're just blasted by the sun because of all the fun things that we can do here. So it's not something that just happens to fair-skinned people. Who can name this person right here? Yep, that's Jimmy Buffett, okay? So he actually died from a rare skin cancer called Merkel cell carcinoma a few years ago, okay? And then, of course, this gentleman here, who's that? And then do you guys know what kind of skin cancer he had that he unfortunately passed away from? He had it on his toe, and what was it? Do you remember? It was a melanoma that he had, okay? That kind of went untreated and went on and on and on and spread and unfortunately killed him. So in order to tell you about skin cancer, we're going to go through three cases here, three different patient cases. So the first case is Mr. Fitzpatrick. So he's a 75-year-old Caucasian man, and he has a persistent scaly patch on his forehead. He initially thought it was eczema or psoriasis, and then he went to Long's and got an over-the-counter cortisone cream. He used it for a couple months, but it just never went away. It started about 3 months ago, and it's slowly growing. That rash is slowly growing on his forehead. It's not bothersome, except it sometimes bleeds, and sometimes it's slightly itchy. So this is Mr. Fitzpatrick. So he came to me, he's referred to me for surgery. So in these photos, you're going to see some kind of sketches of my plastic surgery reconstruction. So just kind of ignore them and just focus on this scaly patch right here. So this is the spot that just keeps growing and just will not go away. So a couple other things to know about Mr. Fitzpatrick is that he has a history of extensive sun exposure at Kailua Beach, where I went to the beach. That was when we still had Liberty House. Does anyone remember Liberty House? Yeah. Does anyone like me miss Dai in Kailua? I miss Dai so much. I wish that it was still there. Okay, so he usually burns and he rarely tans, and he has a history, unfortunately, of 5 skin cancers removed with surgery in the last 10 years. He's a retired postman. So I mention this because if you reflect on certain occupations, certain people, because of their jobs, are going to be out in the sun a lot more. Your contractors, your postmen, other types. So during their career, they're going to have a lot more cumulative sun exposure. So what is skin cancer? Skin cancer happens when abnormal skin cells grow uncontrollably. This is due to genetic mutations caused by sun exposure. So the sun can cause different genetic mutations in different cell types within the skin, and that can cause different skin cancers. So the most common type is basal cell carcinoma, and then I've listed the different genetic mutations. You don't have to think too much about them, but I just wanted to mention it because some patients ask me, well, I have a basal cell carcinoma. If I let it go too long, will it become melanoma? Which is what everyone is afraid of, right? Fortunately, a basal cell carcinoma can never turn into a melanoma because they're due to different genetic mutations. Okay, so that's important to know. Squamous cell carcinoma is due to a different genetic mutation as well as melanoma, and then even rarer types like Merkel cell carcinoma are due to different mutations in different skin cancer cells. So skin cancer risk factors include sun exposure because the UV rays are directly damaging the DNA in our skin cells. Fair skin is a risk factor because you have less pigment or less melanin protecting your cellular DNA. Age is a risk factor because over time, those genetic mutations are going to pile up and eventually declare themselves as a skin cancer. So the most important sunburns are those that occur very early on. So if you have kids or grandkids, make sure to really implore upon them that they should be wearing sunscreen and staying protected because that's the critical period. After a few decades, those seemingly benign sunburns could turn into a skin cancer. So really help them out and remind them. Then family history of skin cancer is a risk factor, as well as a history of sunburns and tanning bed use. So I'm going to just briefly mention the layers of the skin. So the topmost layer here is called the epidermis. That is what we can see with the naked eye, is the epidermis, okay? If someone has a rash, they might have more of this top layer called the stratum corneum. That is why you get scaly skin. When this becomes really thick, that becomes a scaly skin rash, okay? Below the epidermis is the dermis, which we can't see. If you have a cut through the epidermis that goes into the dermis, that's how you get a scar, okay? Any cut with a scalpel knife or any kind of injury that goes through the dermis is going to lead to a scar. Now within this epidermis, there's different types of cells. So at the bottom layer of the epidermis is called the basement membrane, where the basal cells live. Basal cell as in basal cell carcinoma. So if you get a skin cancer in a basal cell, then you're going to get basal cell carcinoma. If you get a genetic mutation in a skin cell that's further up in the epidermis, then that can cause squamous cell carcinoma. And then there's also, you can't see them very well, but there's also living here at the basement membrane, things called melanocytes. And those are making melanin, which is being pushed or dispersed among the epidermis to protect the cellular DNA. Now, when there's mutations in melanocytes, that's how you get melanoma, okay? So this is just a kind of zoomed in photo. So here is the bottom layer or the basement layer of the skin where the basal cells live. These cells that have halos, white halos around them, those are melanocytes, and that's where a melanoma would come from. So for instance, that's a melanocyte, okay? You just have to have looked at these types of pathologic images long enough to recognize them. And then further up, these are called keratinocytes, and that's where squamous cell carcinoma comes from. So in Mr. Fitzpatrick's case, he had a skin cancer that was unfortunately invading more deeply into the tissue, that is into the dermis. So the skin cancer has multiplied and divided, and now it's growing a little bit up, but then mostly down into the dermis. And so this is clearly a problem. This is clearly pathologic and shouldn't take place. This is another photo. So this is squamous cell carcinoma kind of diving deeper into the dermis. So if you didn't do anything about this, this could unfortunately spread into the rest of your body. Okay, that's why we want to address it. So squamous cell carcinoma, which is what Mr. Fitzpatrick has, can be aggressive and it can spread if untreated or metastasized. It often looks like a red scaly patch or a sore that won't heal. Here's another example on somebody's forearm of a squamous cell carcinoma. And then this is a diagram schematic of a squamous cell. I just want to show you that these things, they can grow up and cause this raised border or an ulcer to form, but then they grow down. And it growing down is when it gets dangerous because then it starts attaching itself to blood vessels and lymphatic channels, and then it can spread. So then Mr. Fitzpatrick is referred to me. He has an established skin cancer diagnosis, and he's referred to me for skin cancer surgery or Mohs micrographic surgery, which is what I do full time. So what is Mohs surgery? Mohs surgery is a specialized surgical technique for removing skin cancer. It was developed by Dr. Frederick Mohs in the 1930s, who's from Wisconsin. So Mohs does not stand for anything. It's not an acronym. It's not an abbreviation. It's just somebody's namesake. So that's just something to note because some people think it stands for something. So Mohs surgery removes cancerous tissue layer by layer, examining it under a microscope in real time. So everything is done that day with the patient. It ensures complete removal of the skin cancer while also preserving as much healthy tissue as is possible. So indications for Mohs surgery are that it's commonly used for basal cell carcinoma and squamous cell carcinoma. You can use it for melanoma too, but you need specialized training. And so I did a fellowship in this type of surgery and learned how to use it for melanoma, but there's very few people in the state that do this type of surgery for melanoma. So it's recommended for skin cancers with unclear borders. If you're looking at the skin cancer with the naked eye, you can't really tell where it ends. That's when we have to really rely upon the microscope to guide us with how big the skin cancer actually is. It's useful for recurring or aggressive tumors, as well as cancers in cosmetically and functionally sensitive areas like the face. So for Mohs surgery, what happens is that the patients come and see me in the morning. We'll position them accordingly, and then I'll mark the skin cancer that we can see with the naked eye. And then one of my wonderful assistants is going to numb the area, and then after it's numb, I'm going to use a scalpel blade and cut out the skin cancer that I can see with the naked eye. Okay? Then I'm going to take that tissue to my laboratory, which is just across the hall, and the histotechnologists are going to put those pieces of tissue on microscope slides for me to look at. That usually takes about an hour to an hour and a half. And then they will have generated these microscope slides for me to look at, and I'm looking at the margins to make sure that all the skin cancer is gone. That includes the peripheral margin around the skin cancer as well as the deep margin underneath the skin cancer. So that's all done that morning. If we didn't have the benefit of this technique, what would happen is we'd give our best guess and cut it out, and then we'd send you home, and then you'd come back a week later, and then I'd tell you if it was out or not. And that's quite unfortunate because then you have an open wound for possibly weeks and weeks and weeks. Okay, that was before we had this kind of concept. So repetition may be necessary if the skin cancer is not all out with the first cut. So the national average in terms of the number of cuts it takes to remove a skin cancer is about 1.5. So that means oftentimes we can get it out with just the one cut, but sometimes it might take 2 or 3. And so my job is just counseling the patients and mentally preparing them that it may take more than one cut, and it may be kind of a longer morning for them, knowing that each cut takes about an hour to an hour and a half to process. And then after we confirm that all the skin cancer is gone, then we will approach the reconstruction. So sometimes we just let wounds heal on their own naturally, such as if you have a cut on your leg and the stitches might tear the skin. If we attempted that, we might just let it heal naturally. Other times we'll use stitches, and then other times, if it's very advanced and extensive, we'll do very complicated surgeries where, for instance, I'll take a strip of skin from your forehead and rotate it onto your nose and leave that on for 3 weeks, and then have you come back, and then I'll cut the umbilical cord from your forehead to your nose. Am I scaring you yet? Halloween is coming up. Okay? Okay, so advantages of Mohs surgery is that it's the gold standard treatment for many skin cancers. The cure rate approaches 98 to 99%. So this is kind of the best available treatment we have for many of these skin cancers. It aims toward tissue preservation by minimizing the removal of healthy tissue. We just want to get just enough of a healthy rim of skin around it, but nothing more than that. And then you get your results immediately. Each layer is analyzed that morning during the surgery. It also has a reduced recurrence risk and is effective for aggressive or recurrent cancers. So this is what Mr. Fitzpatrick looked like after I removed his skin cancer. Okay, so a seemingly benign eczema-like rash was actually squamous cell carcinoma, and it had actually gone pretty deeply, so you can see his skull bone right here. Okay, and then I've drawn kind of a plastic surgery design because you have this huge hole in your head. Now what are we going to do? We have to do some heroic efforts to get this closed. Okay, so then this is it after the stitches. Okay, so he's all stitched up, and then this is 1 week later. Okay, so we went with a kind of a pretty sizable hole or puka right here, and now it's all closed, and he has kind of an upside down T-shaped line of stitches. This is going to heal very nicely because the pink color is going to fade and this little scab is just going to slough off. So that's a perfect outcome basically. So now we're going to go to case number 2. So patients often ask me if this happens to people who are older adults, but here in Hawaii, the youth are just blasted with sun. The youngest patient I probably operated on was 16 years old. Okay, and that's just because we love going to the beach and doing other activities. So this is a 35-year-old man, and he has a growing bump on his upper lip. He noticed it about 3 years ago, and this is what happens. People notice things maybe a few years ago and don't think anything of it, but now it's starting to bleed when he shaves, and that's kind of triggering a little bit of alarm. He works as a commercial pilot, which is another occupation associated with a lot of UV sun exposure. Okay. So this is Mr. Chamberlain. So he's a young gentleman, and he has this spot right here. Again, ignore all these purple marks. This is my kind of plastic surgery design here. So he has a history of extensive sun exposure and was a former competitive paddler at Ke'ehi Lagoon. He sometimes burns and sometimes tans. He isn't sure if there's a family history of skin cancer, but he says that his grandpa has had a lot of spots. So he has something called basal cell carcinoma, and this is the most common type of cancer, period, in all of humans, okay? Of any of the cancers you could form in your body, basal cell carcinoma is the absolute most common. That's why, unfortunately, I'm so busy, okay? So these skin cancers are slow growing, and they often appear as a shiny bump or a pink growth. So the basal cell carcinoma will emanate from the basement layer of that, of the skin layers, and then it can grow up and then down. Okay? The fortunate thing about this type of skin cancer is that it cannot metastasize. It does not have the genetic mutations that would allow it to metastasize. So that's kind of the silver lining of the most common type of cancer in all of humans, is that it cannot metastasize. It's just ugly, okay? So this is what it looks like under the microscope. So basal cell carcinoma is very purple. So you can say this is what a normal skin layer should look like, but now there's something emanating from the bottom, this purple, these purple cells. So that is clearly not normal. I'm going to show you a couple photos coming up. Now, this is on the lip. So when you inject numbing medicine into the lip, it can get very, very swollen. So you're going to see some images of a very swollen lip. So I just want to warn you, this is not permanent, okay? Okay, so this is after his skin cancer has been removed, okay? So again, this took multiple rounds to remove this. So this is what his lip looks like now. That's why I wanted to warn you, okay? So this is after I've done kind of a more complicated skin flap on the upper lip to restore his mustache, basically, okay? So all this swelling will go away after a couple days. So this is 1 week later, so it basically looks normal again, okay? And he's gonna have basically a normal mustache appearance. So I wanna just share with you some warning signs for skin cancer. Okay? Skin cancer can look like an open sore that just won't heal. As long as you're a relatively healthy person, if you have cuts or sores, they should heal. They shouldn't last months and months and years. If you've had a sore that lasts longer than 1 month, then you should ask your doctor to take a look at it. There should be no reason why you should have a chronic wound like that. Okay? It can look like a chronically irritated red patch. Maybe it looks like an eczema or psoriasis spot, but you've used the right medicines for it and it just won't go away. It could be a skin cancer. It can look like a new shiny pink bump. Or it can look like a new scar without any explanation. You have a new scar on your face, but you can't really think about why you would have that. You don't think that you got injured or anything. Just be careful, it could represent a skin cancer. So finally is case number 3, which is Mr. Wilcox. Mr. Wilcox is a 50-year-old Caucasian man, and he has a dark spot on his scalp. His wife noticed it about 6 months ago, so he never noticed it. Okay, thank goodness his wife noticed it. The spot has slowly widened and developed a darker area within it. It's not painful or itchy, and it never bleeds. It's completely asymptomatic. It just looks like a large freckle that his wife noticed on the back of his head. So this is the spot here, okay? So you can see he has a little bit of hair thinning, so you can imagine that the sun is just beating down on this area, okay? So it's getting a lot of sun, and he has this large freckle here that his wife noticed. So he has an extensive history of sun exposure as an avid surfer. He usually burns and rarely tans, and he has no history of skin cancer, but says his mom had a skin cancer, not sure what type it was though. He runs a bed and breakfast on the Big Island. So normally melanocytes protect our skin's DNA. So this is a diagram of a melanocyte here, okay? It is generating melanin, and then it's packaging these into melanosomes and distributing it among the skin cells. This melanin helps protect our cell's DNA. It's basically forming an umbrella over our nuclei and protecting the nuclei from the sun's rays, okay? Now, melanoma, when those cells have a genetic mutation and become cancer, it causes melanoma, and that's one of the most serious types. It can spread or metastasize quickly if not caught early, and it often appears as an unusual or changing mole or dark spot. So melanoma under the microscope. So this is a little bit difficult to see, but all these cells that have white halos around them, they are melanocytes. And the problem is that they should just be at the bottom of the skin layer. They should just live at the bottom. But when they get genetic mutations, they can rapidly divide, and then they start pushing upward into the top layers of the skin. And that's called, this term, pagetoid scatter. So these are different histochemical stains, but I can see here that there's melanocytes kind of reaching up into the skin layers, and that's pathologic. That means it's cancer. So that's a melanoma. So melanoma Breslow depth is a measure of how thick a melanoma is. So the thickness of melanoma is measured from a certain layer of the skin down to the deepest part of the tumor. And this is important because melanomas that are thicker have a greater propensity to spread and metastasize. So this is often used in clinical trials and various studies to measure how risky a skin cancer like a melanoma is. Okay? It's one of the strongest prognostic factors for melanoma survival. Thicker Breslow depth is associated with a poor prognosis. So this just means that you want to catch things early before they start growing deeper and that Breslow depth starts getting thicker. So in Mr. Wilcox's case, his Breslow depth, or the thickness of his melanoma, was 0.4 millimeters, and it did not have ulceration. So this is just to say that his melanoma was stage 1A, which is the best possible stage. That's the beginning stage. So fortunately, his wife caught it very early for him, and it had not had a chance to grow very deeply. Okay, so he has stage 1A melanoma, so that means that after surgery with me, chemotherapy is not required for that stage. So that's great. So after surgery, he just needs to follow up with his dermatologist regularly, such as every 3 months, 3 to 4 months, and just keep on going with his skin checks. So this is Mr. Wilcox after the melanoma has been removed. He has this puka here, okay? Okay, does anyone here have a Tesla? No? He didn't either, but I put a Tesla logo on the back of his head. Okay. But then it heals great, and then he's no longer an advertisement for Tesla. Okay? Okay, so briefly I want to just go over the ABCDEs of melanoma. So A stands for asymmetry. That being said, one half of the lesion is unlike the other half. So just look at this melanoma on the foot here, okay? So if I cut it in half, slice it in half this way, one half is not like the other half. B is for border. It has an irregular or scalloped border. So on this side, it has a little bit of a scalloped border. Color, so it may vary in color. So the one on this foot, it's kind of a medium brown, but then there's a darker brown area, so that's more alarming. And then diameter. Melanomas are usually greater than 6 millimeters, which is about the diameter of a pencil eraser. So that's a good way to compare a spot. And then E is for evolving, things that are kind of changing over time. So what you should do if you notice a suspicious spot is to don't wait and just get it checked for that peace of mind. If it's benign, then you got the peace of mind. If it was something, then you caught it early. So don't wait, get it checked. Doctors can diagnose things with a skin exam, a clinical skin exam, and also skin biopsies, which are relatively minor outpatient procedures just with local anesthesia. Treatment options include surgery, removing the cancer, but then also things like various creams. If the skin cancer is not that far along, you can use a cream on it, or you can do things like radiation or chemotherapy if things are more advanced. And then the key takeaway is that early detection gives you the best chance for an easy treatment as opposed to a difficult one. So to find a Hawaii dermatologist, you can scan this QR code, but then there's also this website. And I think that the slide is in your handout, so you can just refer to it later. So there's about 60 board-certified dermatologists in Hawaii that you can go see. There's no such thing as a safe tan. A base tan does not protect your skin from any UV damage. A tan is actually proof that your skin is reacting to DNA damage. So especially on the mainland, I would get patients who would say, oh, I'm gonna go to Mexico on vacation. I'm just gonna go to the tanning booth and get a base tan because that's gonna keep me from getting sunburnt while I'm in Mexico. That's like the worst idea, basically, because any tan is proof, clinical proof that you're getting DNA damage in your skin cells. And then we also have to recognize that getting a tan releases endorphins, similar to kind of like a runner's high, and that can be very addictive for people. So just be mindful of that. There's really a neurologic reason for why people might like getting tan. So my take-home messages are to know your skin and self-check regularly. Also, don't be afraid to check your family member's skin, such as on their scalp or on their back where they may not see. Use sun protection every day and then see a doctor for anything unusual. Okay, thank you so much.
Thank you so much, Wes. That was wonderful. And those surgeries are absolutely amazing. It's amazing to see those wounds and then see what you can do with them after. So thank you. We have time for questions. We're going to try and alternate between the online and the in-person.
So this question is about recognizing what is cancer. So as we grow older, we have dark spots on the skin. And a lot of times, because maybe it's consecutive ones, so they don't look smooth all around. You have some here, some there, and they could be different in color. So in order for it to be cancer, does it has to be like a little wound, you know, because those dark spots that I mentioned, in most part, your skin is still smooth.
Yes.
It's just that there's different colors and different shapes. So but if we are going to go see a doctor for every little one of those, so we might be running to the doctor every week. So it might be good to be able to tell a little bit whether I should go to see a doctor or not.
Sure. That's a good question. So I think one good reason for alarm is if you do develop a cut or a wound in those spots and they start bleeding. But I will say it wouldn't hurt to just get a baseline skin exam with a dermatologist, because then they can look at each of your spots and then they can tell you kind of the pattern. You know, this is what benign spots look like on your skin. So if you just compare to maybe new spots, you can tell. Fortunately, most things are going to be benign. Most things that you're going to point to are either benign moles or they're benign seborrheic keratoses, which are very common, way more common than skin cancer. So it wouldn't hurt just to see a dermatologist just for a baseline skin exam, just to go over the different spots that your body makes.
There's a question online. This lady has a good friend who's youngish with a giant black mole on the side of his nose, bigger than a pencil eraser, that she thinks is growing. I keep encouraging him to see a skin doctor. When are moles serious?
That's a good question. I think it's important in that case, if the patient has had that mole since birth, it's probably not as risky as if they had acquired it over time, because we all get, you know, these birthmarks and they're allowed to occur. It's tough convincing someone who may not want to go. I mean, the thing about me is I see a lot of kind of horror stories where these things happen. You know, it's a selection bias because I'm the Mohs micrographic surgeon, so I'm seeing the worst cases. So I've seen cases like that. I've seen young gentlemen who have spots that they thought were cysts that were invasive melanomas and that needed chemotherapy afterward. So it's really just a good idea to get it checked, just for the reassurance, you know, just to stop thinking about it, because we spend a lot of our time worrying about things that maybe we shouldn't worry about. So maybe just see the doctor and just put it to bed is what I would
think
suggest.
that's a wonderful idea for all of us. Yeah, we have.
Hi, my father had.
Where am I looking? I'm so sorry. I can't see you. Oh, okay.
Sorry. We've been going to the dermatologist and taking off the really ugly big ones, but it was really surprising because the dermatologist found something really tiny in the back of the shoulder that I had never noticed, and a year later he died of melanoma.
Oh my gosh.
It had metastasized and it was stage 3 already. So I just want to say that it's the things that you don't notice that are really important. But my question for you is, there's 2 therapies that are very popular now. Red light therapy, if you could talk about that. Does that have anything to do with skin cancer? And the other is xanthocin, because a lot of my tennis player friends take that to prevent skin cancer.
Okay. The xanthocin, I'll be honest, I'm not familiar with. Is that like astaxanthin? Oh, okay. I will just tell you that most dermatologists wouldn't recognize that as a good therapy. So I wouldn't rely upon that. If you're going to take any vitamin, then talk to your doctor about taking nicotinamide. That is the best studied one. Nicotinamide, also known as niacinamide. That is different than niacin, though. Okay, so that's important to know. Nicotinamide or niacinamide, not niacin. So I would encourage you could try that. And I'm so sorry. What was your first question, though?
About red light therapy,
Okay.
if that has anything to do with.
Got it. So red light therapy is often used for pre-skin cancers, which is also known as actinic keratoses. So that is a field treatment. So patients may get like a chemical painted on their skin, and then they are treated with a special light, and that helps treat pre-skin cancers. But if a skin cancer is very far along, that just won't help. The skin cancer will be too deep, and the red light therapy cannot penetrate deep enough to actually treat the roots of the skin cancer. But that is something that some patients do maybe once a year just to try to keep small things at bay. Good questions. Thank you.
How long should a spot be monitored before a determination can be made that it is not cancer? The spot does not grow and is smaller than 6 millimeters.
So chances are is that it's benign, but I'll be honest, again, for me, it's worth the peace of mind, and a biopsy takes literally 5 minutes. If you're thinking about it for very long, you should just biopsy it, unless it's like on the tip of your nose and you're going to get, you know, a big scar from it. But a lot of these cases, it's just go ahead and biopsy it and then just put it to bed so you don't have to think about it anymore.
Good idea.
My question is about malignant fibrous histiocytoma. Did I say it right? My father had that, and the entire top of his skull was an open sore. It was pretty awful. I've had a few basal cells and squamous cell carcinomas, and I wonder if I or my family would be at risk for my father's cancer, which I understand is fairly rare.
That's a good question. I think in that case, that particular skin cancer, it's probably, unfortunately, a random occurrence to your dad, and it probably has very little bearing to the rest of your family.
Thank you.
If that's any peace of mind.
Thank you very much.
It's okay. Hello, doctor.
Hi.
Hi. This may be a silly question, but can you develop skin cancers on your body where the sun doesn't shine?
Yes. Yeah, you can. You can. So I've treated patients who've had skin cancer, you know, like in their underwear area, and they promised me that they were not like nudist or anything like that, you know. A lot of these skin cancers can also be due, I didn't cover it in the presentation, but some of them can be to the HPV virus, okay? So the same virus that can cause cervical cancer can sometimes cause squamous cell carcinoma, and it likes the underwear area where HPV likes to live too. So those are not areas that you should neglect.
How does somebody come to you? Are you the person, are you a dermatologist somebody goes to just for the basic exam? Or are you a dermatologist that they come to when they have an established diagnosis and they need Mohs surgery?
So the patient would be referred to me for the surgery. So they would see the general dermatologist first.
Okay.
Yep.
What are the chances for identical twins if one has a melanoma?
That's a good question. I think it would depend on, and I guess this is assuming that they've had identical environmental exposures to the sun. Maybe, I guess it'd be different if one twin was very out in the sun and then one stayed inside. You know, if they've had identical exposures, there probably would be a high chance that it could occur in both of them. If they've had the same hobbies and stuff. Do you have any twins in your family? Oh my gosh, okay. Okay, got it. And may I ask, did your twin have a skin cancer? Melanoma. Oh geez, okay. I think that in that case, I would just treat it like, I would just get examined by the dermatologist on a regular basis just to keep tabs on things. What do you call regular? I'm sorry?
What do you call regular?
So it's going to depend on the different skin cancer. So if it's a basal cell or a squamous cell, then it could mean every 6 months. If it's a melanoma, then it could be every quarter. And that's just because certain things are more risky than others.
What is the chance of recurrence? Once you've had a melanoma and you've had it surgically removed, what's the chance that you're going to get melanoma again someplace else on your body?
Someplace else on your body? So I would say probably about 5 to 8%. Within 10 years, about 5 to 8%.
So a good reason to get checked on a very regular basis.
Yes.
Yeah.
Is sunscreen still effective if you apply it, then you sweat it off?
No. That was the easiest question of the day.
Do you have to be referred to a dermatologist when you're a regular general practitioner?
That's a good question. It really, I think, depends on your insurance. Because if you're in like an HMO or something like that, then you might need a referral from your primary care doctor. If you have like a PPO plan, then you might just be able to self-refer to the dermatologist.
I think we have a question right there.
Can you recommend the best sunscreen to use?
I don't think I can recommend the best one. I just will say I use sunscreens that are from Japan that I get from Japan when I go visit there. I really like the Japanese sunscreens because they don't make my skin really white. I think any sunscreen that you use that's relatively inexpensive and that you'll actually buy it and use it is fine. The most common, most popular are like Neutrogena, and that's perfectly fine.
We have an online question. Red light therapy is being used for many other purposes, including increasing secretion from meibomian cells for dry eyes and treating wrinkles. Can it increase mutations?
I don't think so because I don't think it's the right wavelength to cause those genetic mutations. I think it depends on the specific wavelengths of the light that are used, but typically it does not.
Great. Do we have any more questions?
We have a question here about spotting melanoma on the nail bed.
Oh, okay. You're asking how to spot the?
Yes. Yes.
Okay,
how do you
okay.
spot it on the nail?
Well, okay, so the question is how to spot melanoma on your nail bed. So look for a dark freckle that's marching down in a linear streak down your nail as well as kind of up the cuticle, is what I would say. That's a pretty complicated question, though. I think I would just see the doctor if you're concerned about it.
Okay, Gail.
Is there a magic number for skin cream? 8, 15, 40, 75? Depending upon your age, I'm 77.
Oh.
Do I need a different number?
No, I would just, yeah, whatever. Yeah, I think, we have to recognize that skincare, that's like $1 billion industry. So, people want to make different products and market it to certain populations, but, dermatologists just recommend more inexpensive kind of simple things. Like oftentimes we just recommend like a Vaseline or petroleum jelly. There's not a lot of money to be made in that kind of thing, so that's why patients get a lot of other outside information, but that's what I would say.
We have time for a couple more questions, either our online audience or the in-person audience. Anyone else? Okay.
I'm sorry to ask 2 questions, but as for the nail bed, I was told by my dermatologist that unless it's a brown spot, like a circular spot, the line going down from top to cuticle is not a problem. Do you agree with that?
I have seen melanomas that look like that, so it's not a hard and fast rule.
So what do you recommend I do then?
Well, you got to see your doctor.
I already did.
I can't give you
Yeah,
advice
I
here in this
know.
forum,
Sure.
But yeah,
It's-
you have to see your doctor.
It's just that he already told me that couldn't be
Got it.
melanoma.
Yeah.
So, okay, thank you.
Okay. Oh, one more here? Okay.
I have a question about grandchildren. I have some teenagers who are in the sun a lot, and
Yeah, talk right into the.
I have some teenage granddaughters who are in the sun a lot, are professional swimmers here, and I'm concerned about their skin.
Yeah.
Is there a sunscreen that you could recommend for teenagers that are prone to acne?
That is prone to acne. So I think CeraVe is really good. CeraVe AM is great, is what I would say. I try not to recommend specific products, especially because this is like recorded and stuff. I don't want people to think I have a conflict of interest. I don't own any stock in any company, but yeah, like CeraVe AM would be great.
Because they don't want to walk around with white faces, though.
Exactly, yeah.
So it's kind of like, it has a tint in it.
Yes.
Great.
Yeah.
Very-
Or another one is called Elta MD,
Right.
which is very common, and that has a tint in it. But yeah, I would look for sunscreens that specifically have a tint in them.
You would?
Yep.
Okay.
Yeah.
And non-comedogenic or something?
Exactly. Anything that says non-comedogenic is good.
Good, okay,
Yep.
thank you.
Of course, yeah.
Following up on that question, is it better to get the 30 SPF versus 60 versus 70 versus 100?
I would get 50.
50.
Yep, I would get 50 because probably some of it is getting sweat off. So at least if you start with 50, you know, you've tried your best to really get the most protection, knowing that you may not reapply it as often as you should. I usually recommend 50. Yep.
Once you've had a baseline dermatology exam, how frequently should you continue to do this?
I think it depends on what the physician recommends. Sometimes if you've had a completely normal skin exam, you may not need to see them again unless you have a particular concern.
Okay.
But if they find things that maybe they want to watch, or if there are things that they're concerned about, then you might see them every year.
Okay. So follow your doctor's advice.
Yes.
Okay, any last questions? Dr. Mori has been super patient with us.
Okay.
Thank you so much.
Thank you. Thank you.